I want to talk about stable CAD, which is better called today stable ischemic heart disease with coronary obstruction, as opposed to ischemic heart disease without coronary obstruction, INOCA, and microvascular disease. So I will focus on revascularization indications and on diagnostic strategies. So I will lay the groundwork with this question. A patient with a stable angina is found to have a 70% mid-LAD stenosis. What's the likelihood of significant progression of this lesion to a more severe lesion, more symptomatic lesion, or to MI in the next 2 years? And the answer here is A, 5 to 10%. As per CABG angiographic follow-up, outside ACS settings, stenosis over 50% have less than 10% risk of progression over 1.5 to 4 years of follow-up, with less than 5% risk of ACS MI. So it's important to remember that number, 5 to 10% progression in the next couple of years, but most of that progression is symptomatic progression, not in MI. The risk of MI from this lesion in the next 1+ year is in the range of 2–2.5%. It's important to know those numbers to understand the limitation of revascularization and the limited benefit of revascularization for specific lesions in stable CAD. That's different. If I give you the same scenario, but I put with non-STEMI, what's the rate of progression of a non-STEMI lesion? That's 70%. It's over 25% risk of progression. So here, I want you to know, I notice a lot of fellows don't know the names of trials, but those are trials that are very important to know. There are 4 major modern trials of medical therapy versus revascularization in stable CAD. All 4 have not shown an improvement of death or MI with revascularization versus medical therapy. You need to know the 4. CABG, Barry 2D, which was in diabetic, FAME2 trial, and ischemia trial. 2 of those trials, Barry 2D and ischemia, included CABG in the revascularization arm. It wasn't just PCI. CABG and FAME2 were purely PCI. Also, 2 of those trials were higher level trials. They mandated ischemia in order to revascularize. So it was anatomy and ischemia to allow revascularization. And despite that, there was still no benefit from revascularization in terms of death or MI. Okay. Interestingly, also, 3 out of the 4 mandated coronary angiography before you randomize patients to revascularization or versus medical therapy. Ischemia randomized with a non-invasive test only, CT specifically. FAME2 trial is a slightly misunderstood trial. I do want to talk about it. FAME2 was hailed as a positive trial initially, wherein PCI was superior to medical therapy in stable CAD. But in fact, in their primary outcome, they included urgent revascularization and future need for revascularization. And that's why FAME2 primary endpoint was met in a dramatic way. But this was met because of PCI reduced the need for future revascularization via reducing recurrent angina and progression of angina, which we all believe in. However, PCI failed to show any mortality reduction even at 5 years in FAME2 trial. There was a marginal reduction in late spontaneous MI in FAME2 trial, 10% versus 6.5%, but there was no reduction in STEMI, and importantly, there was no reduction in overall MI, no significant reduction in overall MI, because this reduction in late spontaneous MI was counterbalanced by an increase in periprocedural MI and stent thrombosis. Overall, based on FAME1 and FAME2 trials, FFR less than 0.8 is a necessary condition for stenting, especially for lesions that are 50 to 80% stenotic. However, a low FFR does not mandate stenting. You should take into account how severe the angina is. So a lesion with an FFR of 0.8 or less without severe angina may be treated well medically without PCI. I'll describe quickly the ischemia trial, which is the most modern and most important one of those four. So, ischemia mandated that patient have severe ischemia, moderate or severe ischemia, but mostly severe ischemia on stress testing, along with an EF over 35%, mostly 60%, normal EF mostly. And after that, instead of mandating coronary angiography, it mandated coronary CTA to confirm CAD diagnosis, and most importantly, to rule out left main disease. And after doing this, ruling out left main and confirming CAD diagnosis, patients were randomized to medical therapy versus catheterization, followed by revascularization in most of the patients. So it's a different design. It's a design that puts at the center coronary CTA. So it doesn't even mandate coronary angiography to make decisions about medical therapy versus revascularization. Interestingly, also, ischemia trial included a lot of patients with multivessel disease. Actually, most patients had multivessel disease. A good proportion, almost half, had proximal LAD disease, close to half were diabetic, and a quarter of patients received CABG in the revascularization arm. Yet despite all this, despite proven ischemia and despite frequent multivessel disease, at 4 years of follow-up, invasive strategy of stable CAD and the revascularization of stable CAD did not affect mortality, which was 6.5% in both arms at 4 years, did not affect MI or the combined endpoint MI mortality. Interestingly, as you can see here, what happens that revascularization strategy increased the risk of MI in the first 6 months by about 2% via the increase in periprocedural MI. It reduced late MI by 4%, but the balance was still non-significant statistically. Okay. And that's the trade-off. You increase periprocedural MI and stent thrombosis, you reduce late spontaneous MI. Is the reduction enough to counterbalance that? And so far, neither in FAME2, 5-year follow-up, nor in ischemia trial doesn't counterbalance that early harm, partly because the benefit, even that late benefit, is not dramatic. Another very, very important trial, in my opinion, ischemia CKD. So it's a trial separate from ischemia, close to a similar design, that randomized specifically patient with advanced CKD. It may be the only trial I'm aware of, that cardiology trial I'm aware of, that specifically randomized patients with advanced CKD. That's why it's such an impressive and such an important trial. Normally, those patients are excluded from every trial you know of. So those advanced CKD patients who have severe ischemia on stress testing were randomized to a conservative strategy versus invasive coronary angiography plus or minus revascularization. Importantly, they did not mandate CTA. So they took patient, the design was severe ischemia, then randomized to medical therapy versus cardiac cath. They did not even rule out left main via CTA or via coronary angiography in the medical therapy arm, which is a very interesting design. So you would think it's a little more risky because they may have missed some extensive disease or left main disease that would qualify for revascularization. But despite that, there was absolutely no benefit of invasive strategy versus conservative strategy. It was even worse than in patients with no CKD. There was even no split toward the end of the follow-up. So importantly, throughout this ischemia trial, the lack of benefit was consistent across all subgroups, including 3-vessel CAD, proximal LAD, and diabetic subgroups. Importantly, sub-studies of ischemia and of CABG trial have shown, unlike the old teaching, that anatomic severity and extent, meaning, extensive three-vessel disease, was far superior predictor of mortality and MI than the ischemic test severity. Yet neither ischemia nor anatomic severity predicted a benefit from revascularization. At one point in the history of stable CAD, it was considered that ischemia by stress testing or by FFR was more important determinant of outcomes than anatomy. This was based on some retrospective registries. But now we know, based on those two important trials, that actually it's the severity and extent of the anatomy that is more important determinant of outcomes than ischemia on stress testing. So now that ischemia become less and less relevant. That's kind of killing more and more the value of nuclear testing, in my opinion. The only thing that remains valuable, so in stable CAD, beside anatomy is very important, and degree of angina. And most patients in ischemia trial had very mild angina. The same actually applies to CABG trial. So patients with severe angina were, for the most part, excluded. Severe or frequent angina, more than once a week. Why does revascularization fail to improve outcomes in stable CAD? I'll give you some rationale. Significant stenosis has a higher individual risk of plaque rupture and MI, like I mentioned, 2 to 3% per year, than a non-significant plaque, which has a risk of plaque rupture and MI of about less than 0.5%. And if you take FAME trial, it was less than 0.2% even. So it's very low risk from an individual plaque that is not significant, that's not causing ischemia, or that has an insignificant FFR. However, non-significant plaques are much more common throughout the coronary vasculature than significant plaque. And that's why MI or ACS often occurs over a region that is less than 50% stenotic. And those lesions that are less than 50% stenotic are responsible for 70 to 75% of MIs upon long-term follow-up in many registries, including some CT registries and some CAD registries, like Prospect trial, and actually even CABG trial as well. Now, stenting does reduce the risk of MI from those significant lesions. It does reduce that 3%. However, unfortunately, it is associated with a risk of a large periprocedural infarct, which is in the range of 2%, 2.5%. It's an immediate first 24-hour risk of infarct after PCI. It's also a risk of stent thrombosis and severe restenosis. Stent thrombosis is around 1%. Restenosis, depending on the complexity of disease in the DES era, can be around 10% at 1 year. So anyway, those effects of stenting unfortunately counterbalance any of the benefit, and that's why the overall MI risk is not reduced. And more importantly than all this, even events continue to arise from those non-significant plaques. These are the ideas that summarize what I just described. This second idea here, it's kind of a similar concept, but I will further elaborate on it. Atherosclerotic burden, as assessed by CT calcium scoring, is at least as good a predictor of coronary event as the presence of obstructive CAD. Stenting does not modify this major driver of outcome, which is plaque burden. I want to show you this very important study from a Danish registry published in December 2020. So they showed that regardless of the presence of obstructive CAD, it's the degree of plaque burden as assessed by coronary calcium scoring that determines outcome and that trumps the effect of obstructive CAD. So if you have, for example, let's say a coronary calcium score of a very high, in the 400 to 1,000 range, you have a high risk of coronary event even though more than half of those patients did not have obstructive CAD, and the presence or absence of obstructive CAD did not affect outcomes, did not change outcomes that is dictated by the extent of plaque burden. So plaque burden, not stenosis per se, as they state, is the main predictor of risk of cardiovascular disease event and death. So there is a third idea that I want to describe, and this one is extremely important and not much talked about. It's been well described since the 70s. Most often when an 80% stenosis occludes, your infarct is either not large, or oftentimes you don't develop an infarct, or if you develop an infarct, it's a small non-STEMI, not a STEMI. And in those studies in the 70s, when in 80% stenosis occluded, only a third had an infarct. The other two-thirds just had a progression of angina or small infarcts. Conversely, when a 40% or 30% stenosis occludes, you get a massive infarct in the majority of the cases. You get a STEMI in the majority of the cases. That's an important idea. And you see that in a way, we take care of patients with a lot of ischemic burden who've had multiple procedures before and who have extensive CAD. And you notice those patients don't often come with a STEMI. They more often than not come with progressive angina and non-STEMI. That's the idea, is having at baseline obstructive CAD is protective from an infarct for a couple of reasons. One is that you do have collaterals at baseline when you have obstructive CAD at baseline. And two, you get that phenomena called ischemic preconditioning. So prior ischemic events are protective against the size of the next ischemic event. So to sum up this in practical terms, in stable CAD, it's a plaque burden and calcium score that dictates the risk of MI death. Stenosis certainly predicts MI death, but it's mostly, and for practical purposes, determines angina more than it determines the MI and death risk. It's how much plaque burden you have on top of that stenosis that dictates the risk of MI death. For example, you can have somebody with a calcium score of 0 or a low calcium score who has obstructive CAD. His risk of MI is still relatively low compared to the patient with a high calcium score who has the same obstructive CAD. So it's that plaque burden that dictates the MI death. And unfortunately, this is not affected by PCI. It can be affected by CABG in some subsets, as I will describe here. In order to benefit from revascularization, one of the following two features excluded from ischemia trial must be present. So either you have severe refractory angina or severe left main disease regardless of angina. Those are today, in 2022, the two main indications for revascularization in stable CAD: severe refractory angina or severe left main disease regardless of angina. It's based on all what I described. I will go back to LV dysfunction in a little bit. Now, there are other ideas. How about extensive 3-vessel disease or 2-vessel disease with proximal LAD, which are traditional indications for CABG? Those may also benefit from CABG, but less strongly. And I will show you the data in a little bit. I want to just describe what it means, what refractory angina means. Refractory angina means as frequent angina, more than one time weekly, that persists despite the use of at least 2 anti-anginal medications, or less in case of intolerance or low blood pressure, low heart rate at baseline. But the key idea is it must be typical real angina, not atypical random pain. So it must be exertional. And those are the questions that you need to ask. And I notice fellows, when we prep patient for cath procedure, they don't ask those questions. So 1, it must be exertional. 2, you have to ask the patient how many times per week. Ask him what activity brings it up and give him specific examples, housework, walking to your mailbox, carrying a few boxes. And when was the last time you had pain? And that can reveal it. If in a patient who doesn't give a good history, Just ask him, when was the last time you had it and what were you doing? And that gives you an idea about the workload, whether it's a low threshold angina or not. So how many times per week, what activity, when was the last time you had it? Now, in terms of anatomy, so we said the indication in stable CAD is severe refractory angina and bad anatomy, definitely left main. How about 3-vessel and 2-vessel CAD? Where this idea comes from is from 3 old trials from the 70s that you also need to memorize, like the 4 trials I mentioned earlier. CAS, European Cardiac Surgery Study, and the VA study. Those 3 studies and their meta-analysis have shown that CABG reduced mortality in comparison to medical therapy, which was practically non-existent medical therapy in 1970. So CABG reduced mortality compared to nothing. In left main disease, the mortality reduction was 75%, very dramatic. And that's why up until today, because of those 70s trial, until today, nobody will ever dare randomizing left main disease to medical therapy versus revascularization. But also there was a mortality reduction in those 3-vessel CAD or even 1 or 2-vessel CAD involving the proximal LAD. There was a mortality reduction of 40%. And the benefit was more dramatic if there was LV dysfunction with EF. They only randomized patients with EF over 35%, but those patients had more benefit. This is where that idea of 3-vessel and 1 or 2-vessel CAD with proximal LAD benefit from CABG. It's from those old trials. However, modern trials like Barry 2D and ischemia question the benefit of CABG for that, in terms of mortality at least. However, they don't eliminate the potential benefit. And in fact, some sub-studies of Barry 2D and ischemia suggest some benefit of CABG in those subgroups. For example, in Barry 2D, in this sub-study published in JACC, MI but not death was reduced by CABG in Barry 2D overall, actually. So not death, but MI was reduced by CABG, mainly in multi-vessel disease with a high syntax score over 22. So multi-vessel, 3-vessel disease with extensive anatomic burden of disease. There was a reduction of MI. In ischemia trial, in one sub-study published recently in Circulation, MI but not death was reduced by revascularization in the extensive CAD subgroup of ischemia trial, 3-vessel or 2-vessel with a proximal LAD. Okay, so probably there is still benefit today for CABG in those groups, but probably not a mortality benefit. And mainly in those 3 and 1 2-vessel CD with very extensive diffuse plaque burden based on those 2 sub-studies. The important thing I want to mention is, again, it's anatomy that's important. Even when you're deciding revascularization outside angina, it's anatomy, left main, extent of 3-vessel disease. When you're talking about risk of MI, it's about the plaque burden. This is the appropriateness of revascularization guideline from 2017. In my opinion, this document is dead. They have so much focus on ischemia. Look at those guidelines. They were combining anatomy, this, with symptoms, with ischemia on stress testing. They were so focused on ischemia stress testing. But by today's standard, what has weight is degree of angina and anatomic severity. The value of ischemia today is limited to proving that borderline anatomy, is it significant or not? So we have somebody with a lesion of 50 to 70% or 50 to 80%, and he has atypical chest pain. Is this lesion causing his chest pain? This is where ischemia and or FFR are handy. It does not by itself dictate whether you should revascularize or perform medical therapy. So today the management is much simpler. And, you know, I mentioned for those complex advanced anatomy, there is an indication for revascularization with CABG. This is where the data is used. This is where what has shown a benefit in those. It's CABG, whether in the using the old data or the more modern data. It's CABG that has improved MI in the modern data in those advanced subgroups. However, we assume in those patients who aren't CABG candidate, who have those anatomical subsets, we assume that PCI may improve MI and mortality versus medical therapy based on the CABG versus PCI equipoise trial. So that's why those patients with that extensive disease, we do perform PCI when they are not CABG candidate. And here I will mention some guidelines. Those are the new revascularization, ACC revascularization guidelines. They are consistent with everything I described. Even though I had written everything that I described today, I have written that for my book way before those guidelines, but the guidelines that came up afterwards are very consistent. So those are the indication to revascularize to improve survival. The only class 1 in stable CAD is left main stenosis. Conversely, for 3-vessel disease and 2-vessel disease of the proximal LAD, the indication to revascularize for survival improvement is only class 2B. So they do question the value of CABG in patients with 3-vessel disease or 2-vessel with proximal LAD to improve survival. So the only class 1 they for anatomical reason is, and to improve survival, is left main stenosis. That's the only class 1 indication for CABG in stable CAD. Okay. Of course, to improve symptom, they give a class 1 indication for refractory angina. So again, you end up with those two big indications: refractory angina and bad anatomy, mainly left main. Now, to answer the question that I was asked earlier regarding LV dysfunction, here there is a conflict. Is it worth being class 1 indication, somebody with multi-vessel disease and EF less than 35%? Should he get revascularization? The answer to that is the STITCH trial, which randomized those patients with EF less than 35% and multi-vessel disease that would explain their LV dysfunction and no severe angina, and they were mostly heart failure class 2 to 3. They randomized them to CABG versus no CABG, and there was mortality reduction. Wasn't significant at 5 years, it became significant at 10 years. The mortality reduction was in absolute, this you can look at the numbers, about 7% at 10 years. Not dramatic, okay? And it didn't emerge early on. It took 2 years for the curve to start splitting apart. So CABG improves mortality in ischemic LV dysfunction. However, it takes at least 2 years for the curves to start splitting. So it's a late benefit. And the benefit is not dramatic. So the fact that it takes several years for the curves to split tells you that CABG will improve the mortality of patients who are likely to live long enough to benefit from CABG. So you have to make a judgment. Patients who are extremely sick, frail, old, in very severe heart failure, maybe those may not benefit from CABG simply because their mortality is too high early on. And also another sub-study of STITCH has shown that patients who benefit the most are those with an EF less than 27% with a 3-vessel disease, not 2-vessel or 1-vessel with a proximal LAD. So for that reason, there is a conflict here. American guidelines gave revascularization in LV dysfunction class 1 to reduce mortality. Conversely, European guidelines gave it a class 2B. So there is a paradox between the two. And again, the paradox is that the benefit is late and is not dramatic, but there is a benefit. And yes, I believe we should offer that definitely for our patient with ischemic LV dysfunction and multi-vessel disease. I have so far focused on revascularization versus medical therapy and showed that revascularization has limited benefit in stable CAD outside left main and refractory angina. Now I will quickly describe CABG versus PCI in those patients who need revascularization. For 1 or 2 vessel CAD without proximal LAD, it's PCI in general. For 3 vessel CAD or complex 2 vessel CAD with a proximal LAD, both syntax and freedom trials support CABG. PCI is an option in patients with a low anatomical complexity score, syntax score, less than 22, and no diabetes. Those two trials, you need to memorize them as well. They are landmark CABG versus PCI trials. Freedom was exclusively in diabetic trials and showed a dramatic mortality reduction with CABG versus PCI in diabetics who need revascularization. Again, you have to determine whether they need revascularization or is medical therapy alone enough. In multivessel disease with LV dysfunction, CABG, as I described by STITCH trial, possible PCI, we will have the result of the BCIS2 trial soon. For left main disease, both XL and Noble trials, two landmark trials of CABG versus PCI in left main disease, both supported PCI as an alternative to CABG, including in complex distal left main. In fact, PCI seems a more viable option in left main disease than in complex three-vessel disease as per syntax left main analysis. PCI is associated with lower early stroke and peri-procedural MI, but higher late MI and revascularization. Now, after describing revascularization, I want to move on to describe the diagnostic strategy in stable CAD, the second part of this talk. In light of which types of stable CAD patients benefit from a potential revascularization. So anyway, the first step is to assess the pretest likelihood of CAD in a patient who's presenting with chest pain or dyspnea. The old ways of classifying patient is to use that Diamond-Forrester scale, where you have a patient with typical angina. This is what we call typical angina. You need to have all those three features: chest pain, exertional, resolved with rest or nitroglycerin within 5 minutes. And on top of that, beyond a certain age or with a combination of multiple risk factors. If you have that combination, you are considered high pretest likelihood. If you have one of the two, it's intermediate. If you have none, it's low probability of CAD. Interestingly, modern data has suggested that even a patient with a typical angina, so a man 60-year-old with a typical angina, we used to consider him more than 85% probability of CAD, but modern data suggests that the probability is actually, even in those scenarios, is only 20 to 50%. So we tend to overestimate the probability of CAD with those schemes. This has been shown in this very large and very nice analysis published in European Heart Journal. So even in the most typical highest probability patient, you barely reach 50% probability of CAD on clinical ground. Keep that in mind. And when we say typical angina, please always don't consider typical angina as chest heaviness and arm radiation. Chest heaviness and arm radiation are meaningless, in my opinion, absolutely meaningless. There is only one thing that counts: relation to exertion. That's about the only thing that counts. The second thing that counts is how long it lasts. Chest pain that lasts hours in a chronic setting is not angina. Chest pain that lasts less than 30 seconds, especially less than 15 seconds, is not angina. But the most important thing is relation to exertion. So most patients that get called typical angina are either atypical angina or non-angina at all, in my experience. Another important idea I want to describe is dyspnea. Dyspnea is far less predictive of CAD than chest pain. It's far less specific. You often hear that dyspnea can be angina equivalent. Yes, but it is a poor angina equivalent. Dyspnea, if it is due to CAD dyspnea, the CAD must be severe or extensive enough to cause elevated LVDP. Also, you know, the dyspnea that is angina equivalent, in my experience, what distinguishes it is that it is usually fairly rapidly progressive and it will impair activity. It's a dyspnea where they start avoiding doing activity. Like they used to be able to go up a flight of stairs. Now they avoid going a flight of stairs because of that dyspnea. So it will impair activity. It's not that they keep doing their activity, but they don't like it. They don't feel well. It will stop them from doing things, and it is fairly rapidly progressive. Why? Because it's extensive disease. So it's not something that will be lingering on for years. It will manifest in one way or another in a fairly rapid way. So that's dyspnea. And importantly, in terms of pretest probability of dyspnea, at best, it is like atypical angina. So dyspnea is never in terms of pretest probability like typical angina. It is always far less predictive of CAD. Keep that in mind because a lot of our referrals are dyspnea as angina equivalent. Know the limitation of that. And I've seen people fix a CTO, by the way, OM CTO, in a patient who has exertional dyspnea. I mean, you really have to be questioning whether that OM CTO is causing that dyspnea, to do a complex procedure just for dyspnea. So be careful with dyspnea. So after talking about pretest probability, okay, we've established the patient has intermediate or high pretest probability. What's the next step? Low pretest probability, don't do anything. Leave him alone, don't do any test. Intermediate or high pretest probability, you need to do typically further workup. What's the further workup? Now here, ischemia trial has shifted the paradigm, not just in terms of revascularization indication, but diagnostic strategy. Ischemia questions the value of functional stress testing because even severe ischemia on stress testing did not allow a benefit from revascularization. So why make decisions based on functional stress testing? The decisions are best made based on anatomical rule out of left main disease via CTA. Even invasive coronary angiography is not routinely necessary after a severely abnormal stress test. So the classic practice is you have a severely abnormal, you have somebody who has some chest pain, let's say occasional chest pain. You do stress test, he has severe ischemia. Well, the classic practice has been, of course, severe ischemia, he needs coronary angiogram. Well, ischemia trial questions that. Maybe the next step is CTA, make sure they don't have extensive anatomic disease, especially left main disease, to decide about medical therapy. The other thing, based on ischemia trial, if you take ischemia CKD, even high-risk stress test, if they have advanced CKD, but they are not having severe angina, you can just do medical therapy without any further anatomic workup based on ischemic CKD. So it's very paradigm shifting, that ischemia trial. And I will put those ideas in a graph in a little bit. So based on ischemia, CTA is not only valuable in intermediate CAD probability, but also high CAD probability, not just high CAD probability, but also high risk stress test, so high risk patient. In those patients, CTA is an alternative to coronary angiography when angina is not severe. So those are other trials outside ischemia trial that, show the value of CTA, 3 of them, and all 3 analyze the value of CTA in intermediate CAD probability. Ischemia was high CAD probability, high risk patient. Those were more intermediate CAD probability. The Scott-Hart trial was a comparison of CTA on top of functional testing versus functional testing alone. And CTA reduced the risk of MI compared to functional testing alone. PROMISE compared stress test versus CTA, and they had the same outcomes at several years of follow-up. Discharge trial compared CTA to coronary angiography in intermediate CAD probability, which I would say was too much to do coronary angiography in intermediate CAD probability, but we actually do it at times. And this showed that actually CTA has less MACE and less major procedural complications. Both stress test and coronary CT may have similar diagnostic value in assessing the cause of chest pain and in assessing the presence of coronary stenosis. However, coronary CTA and even coronary calcium score by itself as a standalone test likely have superior prognostic value as they quantify the plaque burden, a major predictor of MI beyond the degree of coronary stenosis. Okay. But of course, I talked a lot about CTA, and this is the future of how we should practice, but CTA is suboptimal in several settings, particularly whenever you expect high coronary calcium. So guidelines indicate that age. So age over 70, I would be, you might be reluctant about doing CTA. In ischemia trial, the median age was 64. In Scott-Hart trial, the median age was 57. So age over 70 works against CTA just because you will have inherently some significant amount of calcium. Long-standing uncontrolled diabetes or smoking, they tend to have a lot of calcium. Heavy MAC on echo, they also tend to have the same process that causes MAC, often causes coronary calcium, those endothelial injuries. So those things will work against CTA and will favor you doing stress testing, at the very least to look for prognosis, although it's inferior prognostically, and to make a diagnosis of coronary stenosis. Also, severe obesity and the atrial fibrillation also will be against CTA, will reduce the diagnostic value of CTA. I want to mention calcium score prognostically, but before I'll go back to it, I want to give you the algorithm, the bottom line algorithm of the diagnostic strategy, and then I'll go back to calcium score. So there are three big case scenarios to sum up what I described. High probability of CAD, meaning exertional angina, plus that exertional angina is severe and refractory, typical exertional angina. Those patients, you can refer them straight to coronary angiography and revascularization simply because they have refractory angina, which is a class 1 indication for revascularization. So you don't need to do non-invasive tests. So this is still a subgroup that does not need non-invasive testing in the stable CAD setting. The more common one we see is this one. So they have exertional angina, not very common, less than once a week, not refractory. So less than once a week, it occurs with heavy activity. The next step by today's standard should be CTA unless CKD. So CTA, you rule out left main disease. If you have left main or high risk 3-vessel disease, then you do coronary angio and revascularization. If not, conservative management is appropriate. Revascularization can be appropriate, but they are both equal based on the 4 trials I described earlier. Now, as an alternative, in patients who cannot get CTA for a variety of reasons, whether CKD or whether you expect CTA to not be good for them, as I described here, older age, long-standing diabetes or smoking, and so on, or AFib. So in those patients, you do stress imaging. And if the stress imaging is high risk, you have the option, the old-fashioned option of doing angiography, ruling out left main disease. Or if CTA is applicable for those patients, you can do CTA. But if CTA is not applicable, then in those patients, you would consider doing angiography, ruling out left main disease, and deciding afterward whether you do just conservative or revascularization. And keep in mind that in CKD patients, you don't have to do anything. You can, based on the ischemia CKD, you can just randomize, you can just decide to do conservative management after stress imaging, even if the stress imaging shows high risk. All the stress imaging will confirm CAD, but it won't dictate revascularization. So it's an option to stop here in advanced CKD patient after stress imaging. Then you have a good chunk of patients we see the intermediate CAD probability. In those patients, this is where either stress test or CTA is appropriate. As I described, based on a PROMISE trial, both options are appropriate. Based on Scott-Hart trial, probably CTA is a preferred option. But this is where either one is okay. If low risk, medical therapy, intermediate risk, you do something more advanced like a CTA if you haven't done it in the first time. If it is high risk, again, you do CTA. Okay, so it's best to start with CTA in those patients. So this is my algorithm. The guidelines have a very similar algorithm. So basically, they do the same thing. Low risk, no testing recommended in general. And here I want to highlight, they made one mistake. The term here is not risk, it's probability. It's low probability, intermediate, high probability. It's a common error. Every time we talk about probability. What I showed here, this is a pretest probability here, not pretest risk, pretest probability. Risk is dictated by how severe the angina itself is. It's occurring every day on mild activity and by the non-invasive test. But what you get from this is probability first. So clinical probability assessment here. Anyway, so low probability, no testing. Intermediate to high probability, like I showed here, basically the next step is CTA. They gave a class 1 to stress testing, although I would favor probably lower class to stress testing. They weren't bold enough to give it a class 2A. But anyway, so either one is appropriate. But then you can see the only time you have an indication for invasive coronary angiography and potential revascularization is this: persistent symptoms or high risk CAD. Okay, it's even interesting that even patient with moderate to severe ischemia, if symptoms are not persistent, they were okay with just medical therapy without any further imaging. So they even had an option of stopping after stress imaging. Stress imaging, high risk, they stopped here without any necessarily CTA or coronary angiography. I think try to know this one. This is more simple. High probability with mild angina, CTA, rule out left main disease and high risk three vessel disease, then decide conservative or coronary angiography and revascularization. You can squeeze in the stress imaging, and if you squeeze it, even if it's high risk, you can stop, or you can choose to do angiography to rule out left main disease or CTA. Okay. It's a work in progress. We're getting used to a newer way of managing those patients, but we need to make an effort because that's what evidence shows. Another thing that here I kind of disagree with in this algorithm, I disagree with them. They gave value for FFRCT in dictating coronary angio and revascularization. I disagree with that. The indication is still high risk CAD or frequent angina. Coronary angiogram should be guided by persistent symptoms or high risk anatomy, like with pure CTA without FFR. Ischemia and functional assessment have much less value in the current area of ischemia trial, as I described. FFRCT has value in telling you whether this lesion is indeed a culprit of this patient's chest pain, and it may tell you if it is appropriate to revascularize this specific lesion if there is another indication to revascularize it, such as angina and anatomy, but not by itself. So not FFR by itself. FFR by itself does not dictate revascularization. FFR tells you that it's appropriate to revascularize that lesion if there is another indication to revascularize it, like severe angina and high risk anatomy. So it should not be by itself an indication for revascularization. Keep that in mind. It still has a role, but it's a more narrow role. It's important to understand it. It's not a one-to-one relationship. In additional note here, I want to remind you, what do we call CKD? In the ischemia CKD trial, patients with GFR less than 30 did not undergo any CTA or coronary angiography before randomization to medical therapy. Even in the main ischemia trial, patients with GFR of 30 to 60 did not have any mandatory CTA before randomization. Therefore, in this algorithm, the cutoff to say CKD and avoid any CTA or angiography after stress testing in the absence of refractory angina is a GFR of 30 and probably even 30 to 60 as per both the ischemia CKD and the main ischemia trial. Another idea that comes in those guidelines and that I have in my book is the warranty period idea. So you do, somebody has some chest pain, you do a CTA or a stress test and it doesn't show any significant disease. So they have warranty period. He comes back 6 months later with chest pain. Should you do further testing? So you probably shouldn't, unless there is dramatic objective change. You probably shouldn't. For CTA, the warranty period is about 2 years. For stress testing, they use 1 year, but depending on the age and risk factor, it's probably also 2 years. Pharmacological imaging testing has less prognostic value and less warranty period than exercise stress imaging. Exercise always has more prognostic value than pharmacological testing. So now in patients with known CAD or with known CAD with prior PCI or CABG, also how do you do workup? It's kind of the same algorithm applies to those patients, but with a couple of ideas that you need to keep in mind. If his chest pain was relieved and it was followed by a recurrence of chest pain months later, this is typical of instant restenosis or graft disease, or progression of moderate disease that was not present on your initial angiogram outside the stented area, particularly in patients who present with the ACS. Now, conversely, if you have persistent chest pain after PCI or CABG without a pattern of relief and recurrence, this either implies non-cardiac pain, and so you stented and revascularized for a pain that wasn't cardiac to start with, or residual non-revascularized disease. Maybe that moderate 60% circumflex that you left untreated, maybe it is significant. So those are the two ideas, but always try to elucidate. Did it go away and come back, or was it persistent? And what is the next step? It's the same idea. Repeat the coronary angiogram if it is typical angina on mild exertion. Otherwise, optimize medical therapy. May consider stress imaging or CTA if prior revascularization old, if you're looking to see progression of treated or untreated disease. You may consider it, although again, that will not dictate revascularization, that will provide you a prognosis and diagnosis, but it will not dictate revascularization unless angina is typical on mild exertion. And here an idea comes about CTA in patients with revascularization. Even those guidelines, they give a class 2A for CTA in patients with prior CABG or prior stent more than 3 millimeters. So CTA is actually very good to assess bypass body. They are not good to assess the native past the bypass, especially that the native after CABG calcify more aggressively. So they are not good to assess the native, but they are good to assess graft patency, which is the most important thing we assess when we do coronary angiography in patients with CABG. Okay, so CTA is not terrible in patients with CABG, and keep in mind that coronary angiography in CABG patient is the procedure that has the highest complication rate and the highest stroke rate. I mean, it's still a very low stroke rate, but it's much higher than coronary angiography in non-CABG patients. So that's why CTA is a reasonable alternative in CABG patients. If you want to make a patient is having chest pain after CABG, not severe enough to warrant angiography, not frequent enough, but frequent enough to warrant establishing a diagnosis, CTA is an appropriate test in this context. If there are no questions, I do want to describe quickly calcium scoring. And that will be the last thing I describe here. It is applied to asymptomatic patients for prognostic evaluation, not to dictate coronary angio, but to dictate more aggressive statin and risk control. It's the only coronary test that has an indication in asymptomatic patients. This has also been for 20 years a matter of big debate in the community. Patients want to have a screening for CAD. They have risk factors, they are middle-aged, they want to have screening for CAD like you get screening colonoscopy. Unfortunately, for all the ideas I described earlier, coronary vascularization does not improve outcomes except in the narrow subset of left main and maybe extensive free vessel disease. So it's not like doing a screening colonoscopy. And therefore, that's why coronary testing in asymptomatic patient has not improved outcomes. There are 2 studies actually specifically dedicated to screening diabetic patients who are asymptomatic, which the 2 studies are DIAD study, which use stress imaging, and Factor 64 study, which use CTA screening in asymptomatic diabetic. And none of them showed any improvement in any outcome. Conversely, the only test that has ever shown a benefit in screening asymptomatic patient is calcium score. Part of the reason it showed a benefit is that it did not dictate revascularization. You do the calcium score, you assess plaque burden, you focus on more aggressive statin and risk factor control. Now, a high calcium score, does it mean you have coronary stenosis? Several papers show this. Yes, it has correlation evidently. The more burden you have, the more likely that some of those plaque are stenotic. But the correlation is modest. And if you look at this paper that used calcium scoring in asymptomatic patients, even if you take the high calcium score over 400, 45% had significant stenosis. So more than half did not have significant stenosis. And 20% had extensive three vessel or left main disease. So still the majority did not have obstructive stenosis. Now those numbers would be higher in a patient who's symptomatic and having a high calcium score. It may reach 2/3 or 70% instead of 45%. But again, high calcium score does not mean significant stenosis. It does mean, regardless of stenosis, heavy plaque burden, which is a heavy and a primary driver of MI, at least as much as the extent of obstructive CAD. Okay. Another idea to keep in mind when we talk about calcium score is that about the 20, not all coronary plaques are calcified. About the 20% of coronary plaques on average are calcified. Therefore, the other plaques are either soft, lipid-rich, or fibrotic plaques. So, which means that whatever you see as calcium on that scan, you have 5 times more coronary atherosclerosis, okay? Because calcium score is the tip of the iceberg, it's 20% of the plaque. So we have 5 times more coronary atherosclerosis, okay? Yet despite that, that doesn't always imply coronary stenosis. Another idea is, okay, well, can you have, since calcium, only 20% of plaques are calcified, well, can you have a lot of plaques with calcium score of 0? The answer is, of course, you can have coronary plaques with a calcium score of 0. In this study, you had 4% of people have, non-calcified plaque visualized with a calcium score of 0. But the burden is so low that you're not going to have much plaques. You can have coronary stenosis. 0.4% had stenosis over 50%. If you take symptomatic patients, about 5% of symptomatic patients with a calcium score of 0 may have coronary stenosis, but again, it's very unlikely. Okay, that's one message of that. Another thing that actually, if you have a calcium score in that intermediate zone, which is what we see most often, calcium score of 100 to 400, stenosis over 50% is uncommon. Most patients in that range don't have coronary stenosis, and the overwhelming majority would not have the advanced complex CAD, over 90% will not have that complex CAD. So that moderate calcium score is often okay from a stenosis standpoint, although prognostically, as I mentioned, it does imply an increased risk of MI. Now, this was for calcium score screening, using calcium score for screening, and also some correlation between calcium score and coronary stenosis. Another idea about coronary calcium scoring that has just been gaining ground since 2020 is its use in actually symptomatic patients. Calcium score has never been studied or suggested in symptomatic patients before, but now it's expanding its value to symptomatic patients based on another large Danish registry. Calcium scoring dramatically improved the prediction of obstructive CAD and prognosis beyond that poor Diamond-Forrester approach. Diamond-Forrester, like I showed you in the best case scenario here, even when you think clinically high probability, it's not that high of a probability. So it's the clinical predictors we use, even the best ones, even when we think it's typical exertional angina relieved with rest, even that is at least 50% of the time not CAD. So that's why adding calcium score based on that Danish registry dramatically increased the pretest likelihood and increase the probability of finding CAD by CTA or coronary angiography. Okay, in this study it was by CTA. Most patients with a calcium score less than 100, the overwhelming majority did not have obstructive CAD, even if they are symptomatic. And they were only intermediate probability when their calcium score was 100 to 400. So meaning the majority of patients with 100 to 400 did not have CAD, but anywhere between 15 to 50% had CAD. And this is what has been embraced actually in the current ACC revascularization guidelines and in the current ESC guidelines. They did incorporate calcium scoring in a pretest likelihood assessment of CAD. So if you're less than 100 calcium score, it's very unlikely that you have obstructive CAD. You probably don't need any further workup, even in a patient who is symptomatic. You can stop there. If it is 100 to 400, let's say here, as in that Danish registry, you have intermediate likelihood and you definitely need more testing. Same, of course, if you're over 400. Okay. So it fine-tunes that Diamond-Forrester classification. All right, I will stop here.